Hello, everyone. Dr. David Carley here with davidcarley.com, CEO of Grayledge Technologies. We're going to continue our discussions today with Rebecca McKee. Congratulations, Rebecca, on your recent #1 ranking in the world.
Thank you so much.
45 to 49.
Correct.
Triathletes. Outstanding. So we talked last time, Rebecca, kind of an introduction about regenerative medicine, rehab principles, the work you're doing in Alaska, rehabilitating athletes after injury, and so forth. And we wanted to continue our discussion today, and you're going to kind of lead today's discussion. And I'll be kind of answering Rebecca as though she were an injured athlete looking to get information about regenerative medicine. And again, real quickly, Rebecca not only is a world-class triathlete, but also runs a performance center in Anchorage. And I'll let you just segue and speak to that really quickly, Rebecca, and then we'll dive into this thing. How's that sound?
Sounds perfect. I own the Peak Center in Alaska, and we deal with all types of athletes from beginner to elite to professional, and we do metabolic testing, VO2 max, lactate analysis. I coach many different types of sports, but specifically triathlon, and work with people all over the world. So if you want more information on that, you can find me on my Facebook page at Peak Center Alaska.
Fantastic. Okay, I'm going to let you run the show on this one. We're going to talk about injuries first, so go ahead, hit me.
So like you highlighted, last time we spoke, we kind of discussed this big overview of stem cell procedures, regenerative medicine, and now we kind of want to get in a little bit deeper into the process. And basically, I'm the injured athlete. I just tore the labrum in my hip. I just messed up my knee. I just hurt my shoulder, whatever it is. And we kind of want to give people information on what's the next step. But the first question I always get when people contact me with their injury is, what can you help with? What can stem cell, what can regenerative medicine do for me? So that's my question to you. What can you guys do for us, the injured athletes that have gone out and done ourselves in again?
Yeah, the crux of the problem. So let's talk about maybe the injuries that we treat first, and then we can dig in a little bit more about, kind of the principles of regenerative medicine. So as a general rule, we're approaching bread and butter orthopedic injuries now with a little different mindset. Before, things like ligament tears that weren't full thickness, so partial thickness tears, your more significant sprains and strains and things like that, muscle injuries, tendon injuries, overuse and repetitive strain injuries. A lot of endurance athletes get those types of things. Those are your itises, right? Your bursitis, your tendonitis. And if those get chronic, they can be pretty debilitating. We can approach, we like to look at regenerative medicine from a tissue perspective also. The tissues that we deal with most commonly in regenerative medicine are the ones that don't have a direct blood supply. So things like cartilage, things like meniscus, things like labrums in your hip or your shoulder, tendons. Those are the tissues, because they lack a direct blood supply, have a relatively poor healing capability innately, right? They can't heal themselves very well. So what we look to try to do with regenerative medicine is to provide the building blocks and the mechanisms, the natural mechanisms for repair. And we apply them either by injection or as part of a surgery to the tissue because it can't get there in the first place. So by providing those things directly to the injured tissue, we hope to try to support the healing process that would be slow or inefficient or incomplete, and try to get that tissue to go on to actually heal. And as you know, training yourself and dealing with other elite level athletes, when we go back to sport too soon with an incompletely healed injury, chronicity develops, chronic situations develop, and the problem is that much harder to deal with. So your itises, right? Your tendon injuries, your ligament injuries, muscular injuries. We typically don't approach significant structural problems, so fractures or something that's unstable and requires surgical stabilization from a non-operative perspective. What we do in that situation, like a full thickness ACL tear, for example, what we would do in that situation is look at regenerative medicine principles in conjunction with a surgery. So it's nice because regenerative medicine now fits into the paradigm of non-surgical, surgical, and then also post-operative. Sometimes after a surgery, we'll come back and use regenerative medicine techniques to try to continue to support healing after repair has been done.
Excellent. And I really like the fact that you've highlighted after surgery. We have a lot of individuals that come to me that discuss with me, I had this hip repair, I had this knee repair, and I've just never been 100%, or I'm still in pain. I'm functional, but I'm in pain. And those are individuals that I've sent to you folks, many of them actually, and they've had full recovery. So I like the idea that you highlighted, post-surgery.
Yeah,
And so,
unfortunately, sometimes I think regenerative medicine gets categorized into non-surgical and surgical. And what we've tried to do as part of Graylish Technologies and my own practice and the work here in Vail is to think about it from a spectrum of care, not regenerative medicine is here to replace surgery, or
right.
regenerative medicine can only help with surgery. It should be considered at any point in the care, and that's something that a lot of people miss. And they say, well, okay, if it's a surgical problem, then regenerative medicine is no longer applicable. Not true. We can use it the same in surgery as we can as a standalone injection.
That's excellent. And so, okay, now we have a basis of what it is that you can help with. Now I'm the injured athlete. What do I ask the doctor? What do I come in and ask you in order to get the information I need to make the determination of this is the process I should go through?
Yeah, and this is a really important question because what's happened with, and this is to be expected, I think, to some degree, with any sexy new medical technology,
Yes.
demand supersedes our ability to keep up with it scientifically and actually validate the model. That's natural. That's always going to happen, and it happened here as well. So it created a lot of confusion. It also allowed an acceleration of utilization of things like platelet-rich plasma and bone marrow concentrate, which we'll talk about, because the barrier to use on the physician end is fairly low. Right? You can find a lot of different things to treat with this.
Right.
So what's important to know about your practitioner? Well, a couple of things. One, what's their background going into this? You're seeing all kinds of subspecialties starting to do it. Our wheelhouse is in sports medicine. We've tried to stay there. So I'm not doing PRP facials, for example. I'm not trained to do facials, right? I'm not trained to do that. It's not my specialties. I have no business doing it. We do sports medicine. A dermatologist, different. So what's the background, okay, of the physician? What kind of background do they have with regards to regenerative medicine? Are they attending conferences? Are they participating in those conferences as a lecturer, or are they more of a passive, part of the passive audience? Are they doing any research? Are they collecting any outcomes data? Are they tracking their patients? And what's unique about our program, and I'm unaware of too many other programs in the world that do this, is that we actually quantity control the biologic, meaning we know what we're putting into you.
Right.
So many times physicians do regenerative medicine or cell therapy injection, and they take a sample, they process it using a medical device, and they put it back into you with no knowledge of what's actually in the final product. So the variability from patient to patient to patient is enormous, and there's no quality control as a result. So what we've tried to do is get control over that and then study the outcomes so that over time, what we can do is look at, okay, these patients did particularly well. What was it about their biologic that we can identify as a pattern that alerts us that, okay, this PRP, for example, looks really good. We would expect this patient to do well. Or catch those samples that are sub-optimized,
right,
and fix them before we put them into the patient. And if you don't actually measure, you're never going to be able to determine where that optimization is. This is about optimization, right? And what happens over time as we learn is that we can optimize a biologic for you personally. Right. So a 75-year-old is different from a 25-year-old, a smoker different from a non-smoker. So we can individualize and customize it for you as we continue to learn, and then also for an indication. An ACL may be different from a muscle strain,
right,
which may be different from an acute problem or a chronic problem. So quality is what we've been doing in trying to add scientific validity to this. And getting back to the original question, does your doc know about this, or are they making some magic soup that they're planning you and the magic is supposed to happen? And that's not to say it couldn't work, because a majority of the devices that produce these types of things out there don't do any quantity control.
And I would like to highlight, this is one of the biggest hurdles I'm jumping right now when people contact me, because I don't want them having these procedures done in their local area. Or, you know, my doctor's doing this now. I'm like, well, how long has your doctor been doing this? But also, what procedure are they using? And like you said, what is their quantitative information? Do they know what they're putting back into you? And I mean, 98% of the time, the answer is no. And that's the reason why I came to you guys, because you were going based, and we talked about this before, on the science.
Right.
There was a science background for this.
And in order to move the field forward and get better at what we do, we have to provide that scientific foundation. The other thing not to neglect is getting back to your doctor and what should you know about your doctor. There's not a lot of formal training in regenerative medicine,
Right.
residency programs or fellowship programs. It's usually continuing ed after your training is over. So where are they going for their training? Who are they learning from?
Right.
You know, how many have they done? Is it the first shoulder they've ever done?
Right.
Well, that's something you should know about. That's not to say that they're bad or that they can't help you, but you need to know that.
I agree. And this actually kind of is a perfect segue right into my next question, which is, there's so many of these terms. There's so much information out there. There's the PRP, there's, you know, stem cell, you hear the BC or BMC or BMCC, and you hear regenerative medicine. Can you speak to what do all these different terms mean, and what am I getting when I have these different procedures done?
Yeah, incredibly confusing, unfortunately, because again, the field has kind of taken off without you know, the scientific validation to support it. So as a general rule, there are two products, regenerative products, cell therapy products, that we focus on, and I'll go into why. But they are PRP, or platelet-rich plasma, which is where we take a blood sample from a vein and we concentrate your platelets and some of the cells of your blood. And as we implant that into an injury, for example, what happens is the platelets release growth factors, which facilitate and support healing, right? That's how we heal normally. We're just delivering them where they're not going to get to. It's the simplest regenerative medicine technique. So very basic itises, tendonitis, bursitis, soft tissue injuries that aren't real significant, will apply platelet-rich plasma. The second therapy that we're working with, a little bit more sophisticated, is, as you mentioned, BMC. That stands for bone marrow concentrate. So what we do here is we take a blood sample from your bone marrow cavity, we concentrate the cell populations, including stem cells. It's important to note that there are many types of stem cells, not just one type of stem cells, many types. So we concentrate them along with the platelets, and this is something that a lot of people forget. There are platelets in there too, right? So we got to measure all of that stuff. Right. So it's cells and platelets together being implanted. We can talk about using one versus the other, but BMC and PRP are the two primary biological options that we have at our disposal, and they're all made from your tissue. So we're not taking someone else's tissue and using it on you, okay? That's a totally different model. Why do we focus on those two? Well, a lot of it has to do with federal compliance, what we're allowed to do legally. There's fat-derived stem cells. There's amniotic fluid-derived stem cells. Right. There's placental-derived stem cells. Based on a very extensive review of our obligation as providers and as industry, as CEO of Graylish Technologies, legally we're allowed to use PRP and BMC without a formal FDA approval. So when someone says PRP is FDA approved, that's incorrect. Okay. PRP is FDA allowed. BMC is FDA allowed. And I won't get into all of the specifics, but fat-derived cells, depending on how they're manipulated, any cell from another entity other than you, placenta, amniotic tissue, another person, has to go through a drug development pathway that takes many years and lots of dollars, but they're not approved nor indicated for routine use on you today in the United States. Okay. We're just talking about the U.S. here. We're not talking about abroad, different animal. But in the U.S., PRP and BMC, we're allowed to use for basic orthopedic application.
All right, and it is really confusing, and there's a lot of information on the internet that you have to recognize is for other countries, because these things are allowed and approved in other countries, but not in the US. And so that kind of takes us kind of a big full circle here to, okay, I know you can help me. Now that I've done the research and I've learned about what it is that you're providing and who you are as a doctor, and I have an injury that can be, that can benefit from one of these procedures, how can I help to get myself into your office? What do I need to do as the athlete, the patient, the client that will help you get me in to be able to have one of these procedures done? Because that's a whole nother set of hurdles to understand.
It sure is. And I'll use our practice as an example, and other practices may differ a little bit, but what we like to do, because so many patients fly in from far away
right
to receive treatment for this, is to at least do some type of remote screening. So we have a basic questionnaire that talks about some history. It talks about some of your health history, your injury. It's not a full history and physical, but it's just some information that allows us to get to know you a little bit, get to know your injury. And then typically we'll ask if you've had imaging done, x-rays, MRI scan, CT scan, things like that. You send them to us so that we can screen them ahead of time and at least get a feel for whether we think you'll be a good candidate or not before you fly all the way in here. What we don't want is for someone to fly in and be told, no, you're not an appropriate candidate.
Right.
So by and large, we can determine who's a reasonable candidate. We make the final decision, of course, when you're here in person, but we can pretty much determine that. So most patients will need a pretty full workup. We need to evaluate your injury and not guess. These are expensive procedures. It's your hard-earned money. We try to counsel patients to think about this a little differently. Not insurance is going to cover it.
Right.
It's an investment in your body, an investment in your health, an investment in your career if you're an athlete who does that for a living. So you look at it from a return on investment perspective, right?
Right.
So like anything, a good diagnosis is first. If we're guessing, the outcomes will reflect that and be less significant, less effective. So whatever imaging needs to be done, that needs to come first. Sometimes we'll organize that remotely. Sometimes we'll do it here. Okay. Then a good, like anything, history and physical exam. We need to touch you. We need to move your joint around. We need to see where you're tender. All of those things that doctors do, right? Doctor 101.
Right.
Make a determination if you need a stem cell talking to you over the internet. Okay. You need to put your hands on you. Do a physical exam, do a full history, make sure there are no contraindications or reasons not to do this, like a bleeding problem or history of a blood cancer or something else. So it starts with diagnosis. If we're effective at making a diagnosis, it makes us much more specific in our placement and implantation of the biologic, and the outcomes will reflect much better results from that. So when we're coordinating remotely, we're working with you, or we may be working with your docs, your local docs, to try to get some things done that we think are necessary to determine your candidacy, and we go from there.
All right, excellent. Well, I think that was all we had for this session on our questions. Did you have anything you wanted to throw in?
No, I think it's great. It's so confusing out there. It's so difficult. I'm glad we're doing this, and thank you for taking the time, Rebecca, because it's so helpful to patient consumers who are evaluating this as a possible option. Let's continue to dig into it. Hopefully this is useful to the audience, yours and mine, to try to navigate tough waters.
Yeah, and for sure, I think the next session that we do, we're going to actually move a little bit into, okay, I'm coming in, what next? And just kind of keep these a little bit short, but very informative, and hopefully help people literally wade through the waters of trying to understand this stuff and figure out if this is the right path for them.
Absolutely. And a parting thought as we wrap this one up, our job as clinicians first is to do no harm, right? That goes back to our Hippocratic oath. Don't cause more problems than you solve. So when we're evaluating you from a regenerative medicine perspective, yes, we want you to do better, but sometimes not doing regenerative medicine is the best thing. Not everyone is a candidate. You have to use good decision-making, as with everything, in order to get it.
Excellent.
All right. Well, thank you as always, Rebecca. We'll continue our talks. I always enjoy talking with you. Super informative. And great job again on the ranking number 1 in the world, ladies and gentlemen, right there.
Thank you.
Nice to be number 1. And we'll look forward to talking with you soon.
Perfect. Thanks, Dave. Bye.
Bye-bye.